Welcome everyone to today's webinar on bundled payments programs featuring key findings from Chilmark Research's latest report, Bundled Payments, Current Strategies and Tools. I'm Hannah Emley, Chilmark's marketing lead and today's webinar moderator. Before we begin, I'd like to introduce Chilmark Research. As an analyst firm, we are united by a core belief that effective deployment and use of IT is essential to modernizing care delivery and ultimately improving the patient experience. We monitor trends and developments in the industry with a focus on those technologies that will be transformational to healthcare delivery. We provide comprehensive, objective, high-quality research for busy executives. It's our way to create a more informed, future-ready market of products and consumers. I should also note we are recording this webinar and will include it in our follow-up email. If you have any questions during the presentation or discussion, please submit them via the Questions tab in your GoToWebinar control panel that should have popped up alongside the presentation screen. We will address them at the end of the webinar as part of the discussion. Leading today's webinar and presenting highlights from the report is Chilmark Analyst Matt Guldin. Also joining us is Andrew Tessier, Director of Business Development at Signature Medical Group. Andy will share some results and lessons from Signature Medical's Bundled Payments Program. With that, Matt, would you like to tell us about the research?
Great, thanks, Hannah. Just wanted to start today by giving a brief overview of the focus of the report itself, talking about some findings on the overall market in terms of current state it's in, and then just giving a brief overview of some of the vendors that are in this marketplace and the maturity of the technology solutions that they're offering today to help providers meet the needs for fulfillment in bundled payment programs. So just wanted to start off with the report focus and what was actually covered in this report. We took a look at vendors who were supplying IT solutions and or service offerings. They did have to have an IT solution to providers. And again, this was focused on solutions that were for procedure-based or acute bundles that had some type of anchoring event or procedural event to initiate the bundle. We weren't focusing on chronic care bundles or other types of bundles that are emerging in the marketplace. In terms of the vendors that we analyzed, they were really put into 5 buckets. Acute care EHR vendors, care management vendors, consulting firms, medical device manufacturers and vendors, and niche episode payment vendors, which is basically a number of startups in this space and are focusing on bundled payments and have somewhat of an underwater focus in some cases. In terms of bundled payment adoption, we wanted to try and get a sense of just how widely adopted bundles are in the marketplace. There's not necessarily a gold standard for this data, and what we did to try and address this question was look at some of the data from Definitive Healthcare, a provider of healthcare data that we utilize, and analyze what has been the adoption or uptake of CMS programs, particularly the BCI program and CJR program by various hospital institutions. Look at a couple of different ways to divide this data and cut this data up last year. One of the ways we found that was most clear and straightforward was using annual patient revenue per facility or per organization to really kind of get a better sense of how the adoption is taking place. There was a clear difference in organizations that had less than $1 million in annual patient revenue, as noted in the slide, only had 8% adoption of bundled payment programs. Whereas if you went to organizations that had $1 to $5 billion, jumped up to 34%, and then up to 47% for organizations greater than $5 billion. This shouldn't be a surprise, as larger organizations typically have a greater penetration of value-based participation in value-based payment programs, and we found general correspondence to that. So organizations that are less than $1 billion typically are in that community hospital space, 200 to 300 beds, maybe a 2 or 3 hospital facility organization or IDN, typically less than 500 beds. This may have changed a little bit over the last year or so, especially with some additional participation in the advanced BCPI program. But we think that these numbers are fairly apt in terms of describing and taking a look at the marketplace. In terms of using this as a proxy for a commercial adoption, we feel that a lot of organizations, if they're going to participate in a bundled payment program, are choosing to participate in a CMS program first, and then choosing to participate potentially another program with a commercial payer or self-insured employer. So in terms of bundled payment growth drivers, we really wanted to look at kind of three core stakeholders here and what their viewpoints were in the marketplace and kind of how that was impacting the adoption of bundled payments by providers. So really the core stakeholders here, CMS is an obvious one. Over the last 2 years, there's been a lot of mixed messaging from CMS about where they stand on bundles. When Tom Price came in as Secretary of Human Health Services, he clearly had a fairly negative outlook on bundles, but had kind of a mixed outlook on bundled payment programs and using those as a value-based payment program vehicle for CMS to achieve their goals. He definitely wanted to move away from mandatory bundles and definitely made some changes in the CJR program that were taken as the marketplaces that CMS was taking the foot off the pedal in terms of moving from bundles, especially from mandatory bundles. Since Azar was appointed to replace Price as Secretary of Human Health Services, I think we've seen a real sea change in terms of how CMS is focusing on this market. There was an address a little over a month ago where Azar noted that there's likely going to be a mandatory bundle payment program coming for oncology. Details were kind of scarce, but certainly indicating that CMS was going to double down on bundled payments and look to move towards some type of mandatory bundle for oncology first and looking at potentially other service line areas in the near-term future. In terms of the VCPI Advanced program, which is the successor to the initial VCPI program, there was significant enrollment in this. I think the official number is about almost 1,300, 1,299 organizations. We did an analysis to see overlap from the initial VCPI program. As best we could tell, very high overlap between the original participation for VCPI organizations that are in this next generation program as well. But there's some early indications that some of these organizations may drop out once they realize how difficult it is to achieve and hit some of the payment thresholds depending upon the model that they selected. Early reports are kind of fuzzy on this, but we anticipate about 15, maybe up to 20% of organizations, once they realize how difficult it might be to achieve some of the savings in these programs, may drop out. But again, I would anticipate probably a 10 to 15% attrition rate on that 300% number. This is really the key program for CMS moving ahead forward for bundles, as well as the existing legacy CJR program and the oncology care model. So CMS definitely has been pretty aggressive with bundles and looking to use bundles as a vehicle to enable value-based payment, including as an APM for providers that are participating in the bundle payment program. In terms of the commercial payers themselves, again, not a great standard for data out there. Adoption is kind of ad hoc based upon several conversations we had with various payers. We've seen considerable variation by geography and episode type in terms of in the marketplace itself. Where we have seen some differences, though, has been around cancer care, particularly chemotherapy, radiation oncology. Anthem and United Healthcare have been fairly aggressive in this area. But generally, I would think it's fair to say right now, the commercial payers have basically been following what CMS's lead is and picking up from it and moving into areas in terms of with the VCPI Advanced program payouts and adopting that, as well as following suit with some of the CJR program and the oncology. Then lastly, we just have self-insured employers. Again, we took a look at some survey data from the National Business Group on Health, Pacific Business Group on Health, Midwest Business Group on Health, and several smaller regional employer coalitions. What we saw here is there's definitely robust interest in adoption among the Fortune 1000 companies of the National Business Group on Health survey results, building on the legacy Centers for Excellence program concept that a number of these employers already have in place, and looking to move a little bit further with this in terms of additional bundles that they might consider, and actually forcing employees to go or utilize certain facilities only, instead of just giving them incentives to do so. Outside of that larger group, there's definitely much more limited adoption of bundle payments right now by self-insured employers. I think it varies considerably here. There has been some activity that we've seen from public employers, large state governments have been considering this, but seem to have been tepid with adoption. And again, with employers that are a little bit smaller, that aren't necessarily kind of multinational or even national, several different sites in the United States have been somewhat slow to adopt or consider adopting bundled payments, but there is interest there. In terms of what we saw from the design and operations challenging phase, really data sharing and analytics is a core underpinning of kind of all of the issues that we're seeing across healthcare. It should be a surprise and is very much in common with any type of value-based payment program. There are some different complexities, though, with the bundled payments program, especially around the patient identification piece of this and the episode definition of pricing. Especially in the commercial space, if the commercial payer is trying to adopt, create their own commercial bundle, there's definitely, from a retrospective standpoint, it's a real challenge to try and set up a bundle in terms of the length of that bundle, the carve-out conditions, what should be the initiating event, and then once that bundle is actually identified and agreed upon, how you identify patients once they come into that. A real challenge for payers and providers to work through those two pieces. Retrospective bundles, not as much of an issue for prospective bundles, but adoption of prospective bundles has been very neat to date. In terms of some of the inter-organizational issues, again, just patients getting care across several venues of care for a particular bundle during that 90 or 120-day period. Very different change focus for organizations that historically have focused just on providing the procedure itself, doing some maybe doing some basic post-op follow-up work. Essentially, once the procedure was completed or the event was finished, the organization provided that their role was pretty much limited. That really has changed. And that's also the issue of patient volumes and flow. As a percentage of your patients are involved in these bundle-based programs, you need to set up different workflows to accommodate them. This becomes considerably more challenging and complex if you have 3 or 4 different types of bundled payment programs in place for a particular procedure and organization. It quickly causes problems in trying to scale that solution across additional patients or additional facilities within that organization. And this is lastly around the patient engagement on the side of things. Certainly something you're seeing a lot more talk of in general in health IT. Certainly see this as a critical piece for elective-based bundles. There's pre-work that can be done, engaging the patient beforehand to make sure that the surgery and the patient are in a good place, ready to be successful or have a successful outcome in terms of the procedure itself. And then lastly, in terms of the quality and cost management pieces here, every one of these programs has some various degree of quality measurement reporting requirements that come with it. You obviously have the cost management efforts that need to be in place to track how the organization is doing, and then at the very end to be able to figure out what providers did, the work they did, and how they should be reconciled against the target public funds. So we just wanted to use an example here of what we found. We're talking to some organizations around orthopedic bundle. We're talking here about partial pain hit, mainly costs that could include spine as well. In terms of looking at this, where the cost savings were, this definitely differs for some of the types of bundles that are out there. I think cardiology, there'd be a fair degree of overlap, although the implant cost piece definitely may change depending upon the cardiology-based procedure if there is an implant in general. Again, where we saw the highest degree of cost savings here should be a surprise on really length of hospital stay, the device and the implant cost itself, skilled nursing rehab facilities or other types of post-acute needs, and then reducing readmissions, typically a 7 or 3-day readmission, depending on the procedure. Less cost around inpatient rehab cost facility and potentially converting the patient to just a skilled nursing facility, or in some cases where appropriate, even home discharge directly to the home without outpatient-based patient occupational therapy as appropriate. Avoiding surgical infections and major adverse events. Where we see less savings in this particular area is around the actual OR facility itself, in terms of saving some of the supply costs there and some of the pre-prep work with that. Again, there are some savings that can be had there with the low area side of things. I think this is really important, though. What I'm trying to demonstrate here is that in this particular bundle, there are some definite high cost drivers around the hospitalization and the implant itself. Moving across the various types of bundles, though, these cost savings can radically differ from bundle to bundle, and I think really presents design challenges, both in terms of how the organization should consider pursuing adoption of bundle-based programs, but then also reorienting their peer design efforts accordingly to make sure that they have success in that particular service line for the bundles that they participate in. In terms of what we found as the most challenging activities, we really bucketed these into 3 phases. We heard a number of different challenges within each of these phases in terms of what providers thought they thought was going to be most challenging versus what they actually found to be most challenging. In terms of the design phase, again, just creating a risk and gain sharing agreement, especially for a new bundle or something that you're not necessarily taking what CMS has done and adopting most of that criteria to create their own bundle in the commercial space, creating attractive physician alignment models, especially for physicians who are not employed physicians or only affiliated physicians. There has to be enough upside here for a physician to participate, and then also something that can be realistically attainable, that the physician feels that they have within their scope of control in their organization of achieving those targets. And then lastly, the care redesign efforts. This is pretty straightforward again, it just requires a general sea change in terms of organizations that typically did the procedure, would finish with the patient and hand them off. They now have to be worried about that patient and how they're doing for some duration of time afterwards, up to 120 days. We've seen a couple of examples of 1 year programs. That's pretty unusual, though. There may be 120-day periods that seems to be very much the norm for most of the procedure-based bundles we've seen out there. In terms along the implementation side of things, it's persuading physicians who are participating in these programs to deliver against the bundles. That entails and requires giving them timely information around cost and quality information as the patient's progressing through the bundle, providing them timely information about when the patient is actually in the bundle itself, what care settings they're moving for, and who's doing what. Yeah, a large challenge from an IT perspective. It really has required a sea change in terms of how organizations handle and delegate these things. And then lastly, integrating clinical and administrative claims data. This is a challenge that is common across healthcare right now in any type of analytics endeavor. Certainly is the case within bundle payments and being able to reconcile these 2 data types within IT solutions. Then lastly, on the operations phase, this really comes to the issue of scaling. There's several different aspects of scaling. You have these types of conversations with provider organizations that are challenging from them. One's just a matter of scaling the number of procedures and conditions that the organization's involved into. When you talk to organizations, they might be doing bundles in maybe 1 or 2 surgical service line areas around 3 or 4 base procedures. Moving that to an additional service line or scaling that up across different procedures is very much a challenge, especially if the criteria for that bundle for that particular procedure differs greatly from one payer to another. And then lastly, this issue of trying to scale this up from the number of facilities or geographies. So in terms of taking what you've done at one facility and trying to move that to another, that often are 7 different considerations that need to be in place there. It has been a challenge for organizations that are trying to do this, move this across their service lines in the various facilities across a broader geographic basis. So we wanted to talk about some of the vendor strengths and weaknesses here that we found in the report. We really wanted to first start by what we found as kind of the 8 functional attributes or requirements for IT vendors in this marketplace that providers are asking for, and what was most mature to least mature. So in terms of the attributes that were most mature, and this should be a surprise, it's the cost and quality reporting. Again, each of these programs have some level of quality reporting submission requirements that are part of them and have some type of cost that the organization needs to understand how they're performing against that bundle. So the cost and reporting, the cost and quality reporting metrics are definitely the most mature from what we see in solutions in the marketplace. Where we see a slightly less degree of sophistication is around the care navigation workflow solutions. That typically is a solution that is anchored by a care plan or a care plan-like solution basis that tracks what is occurring to that patient across multiple care settings, ideally as they're within those care settings, so that the convener or the IDN who's in charge of that bundle of bearing risk can basically understand where the patient is, what's happening to that patient, and ideally prevent them from having a hospital readmit or ER type of or ER emergency room visit. Patient engagement, again, where we see solutions with this, they may be a module as a part of the patient navigation workflow solution, it may be an entirely separate solution that's provided either through a partnership or an acquisition that that vendor has made. Varying degrees of sophistication here in the marketplace in terms of how closely that solution is integrated with the overall vendor solution set and the degree of functionality for which that patient engagement solution is provided. Lastly, it's really around kind of the payment and actual design of the solution. So in terms of the contract management and reconciliation piece, which is really a key critical aspect for retrospective bundles, given the administrative complexity and issues of actually figuring out who did what, reconciling that against agreed upon prices, and then putting in a check and sending it. Still a high degree of manual workflows required to that, even if these solutions themselves can provide a pretty good level of analysis about who did what and how they should be paid. Still a high degree of manual requirements here typically in terms of actually sending the paychecks or paying payments. Again, kind of a combination in general with healthcare, but certainly an issue that you're trying to scale these programs up and move to larger patient flow volumes and make that quite cumbersome. And in terms of the episode definition itself, a number of the smaller firms that are really anchored or focused on this area have this capability baked into the cake. Other vendors have varying degrees of sophistication around this in terms of how they handle this, typically around just alternate business flows within their solution. But again, not necessarily a great level of sophistication in their solutions. Certainly can be kind of timely, kind of time consuming in terms of trying to set that up and tweak these solutions to handle the actual episode definition itself, handle carve out events, and several other pieces that involve actually setting up the definition of an episode. And then lastly, just around the opportunity analysis and clinical pathway support. The opportunity analysis is not only really just taking a bunch of claims data over the last, let's say, 2 to 3 years, analyzing that data and looking at where the opportunities may lie, or the best area of opportunity may lie from the organization from a pricing standpoint, but then kind of 2 steps beyond that. It's in terms of taking that data to align that against providers within the organization or affiliated providers in terms of who they should partner with and how they should maybe alter their network, what types of services additionally they need a contractor consider to bring into their particular bundle to meet the needs for this, and why and how should they consider it. And then lastly, being able to monitor that performance or forecast that performance of what are some of the various scenarios may play out depending on how they choose to set up and manage their network. Again, very early phases from what we've seen there. It's pretty much more standard as a part of consulting arrangement where solution would be utilized just to analyze the opportunity for the organization itself, but not some of those more advanced functionalities that we just described. And then lastly, clinical pathway support. I think that what we've seen here, and recently a low lack of maturity, is really 2 factors. I think one, for some bundles, in particular, clinical pathways really just aren't necessarily applicable or relevant, especially if it's a non-surgical event in terms of moving forward this. I think 2, it's a lack of solutions that are in the marketplace from the clinical decision and support vendors themselves in terms of supplying a product which can meet their needs in terms of feedback and how that content will be utilized for a particular bundle. And I think 3 is just a lack of willingness or ability to pay for these solutions. It's considered an upsell solution in a lot of aspects. Small organizations don't either have the money or inclination to pay for that and take what's out there in public domain from several different sources. And larger organizations typically, especially a really large IDN, that would have some type of sophistication around managing their own clinical pathways themselves, there's a real reluctance to purchase this content. Very curious to see if this is going to pick up in the future, but that's certainly where we see the least maturity in the marketplace from solutions and vendors offering that capability. In terms of the profile of vendors, just want to walk through this relatively quickly, some of the profile vendors in the column here in the report itself, and I just want to talk about some of the strengths and weaknesses of these respective 5 groups of vendors. From the acute EHR vendor space, these vendors certainly have the ability to support the hospital workflows themselves, including the ER, OR for these particular procedures, or the bundle event itself. I think where we see no challenges here is it's a matter of putting together a more complete, comprehensive set of solutions, and then matching that to the needs of an organization, especially in the post-acute phase and some of the patient engagement pieces. These vendors do have varying offerings in these spaces or in these capacities, but I still think it's very much a work to date. And we're going to see these larger organizations look to develop more mature and tighter messaging and also IT packaging of these solutions over the next year into 2020. In terms of care management vendors, again, this was kind of a broad group. We did include Optum in this vendor categorization. I'm sure that potentially some would not. What we found here basically was an emphasis on the cost and quality reporting. These solutions typically have a strong area to focus on that, have some level of tracking more following the patient through a care navigation workflow perspective. Where we haven't seen a kind of standardization approach is that there's not necessarily a holistic approach in terms of what these organizations are doing with bundles, again, varies from vendor to vendor, and not necessarily an immediate focus on the post-discharge follow-up while the individual is within the bundle itself. There's some workflow challenges there that we've seen some of the solutions in the marketplace that vary. That's being offered by these vendors, depending on the data sources that they use and how they structure their offering. In the consultant space, again, Premier, not just necessarily classified as a consulting organization per se, but we put them in there because of their strong emphasis in service offerings and the learning collaboratives that they have to date. Again, ability to focus on analytics and reporting through report metrics, very sophisticated degree of service offerings, including some of the collaboratives that we mentioned in terms of that bundle payers or providers can join for a certain fee and talk to other providers, and part of those engagements and then offering a pretty full range spectrum suite of service offerings to help providers with bundles from design to the care design and so forth. I think where we see more challenges here is just some of the functionality of the solutions getting outside of the core cost and quality reporting. Really something we desired both from Premier and a couple of other consulting firms that we talked to that have service offerings in the space, offer some type of basic reporting and analytics solution, but not necessarily a more full range of solution suites. In terms of the medical device manufacturers, what we've seen here, again, a number of these manufacturers have set up some type of services arm to support their devices themselves, and definitely have a strong area of focus on the actual areas of care delivery itself, especially on the OR and some of the OR supply support pieces there. They all have some level of offering around analysis and reporting performance metrics, participation in these programs. A lot of these were primarily set up for BCPI and then CGR in particular, in terms of making sure they had at least some basic level of offering to support some of their customers who buy their various devices, especially orthopedics. Where we've seen some challenges from these programs, mainly to date, these programs have focused on the CMS programs that are out there. They have not created offerings or solutions for commercial programs, and where also in terms of the breadth of portfolio and depth of their solutions. They typically have a pretty limited portfolio of solutions that they offer, and they often rely upon partnerships to meet a number of the functional attributes and requirements that we identify from an IT perspective. And then lastly, we classify this as the niche episodic payment vendors. Some of these vendors have a much broader focus in this, but they certainly have the capabilities to deliver what we consider more of a full solution suite for bundled payments and success in those. Where we saw success here, again, we talked about is the ability to define bundle inclusion and exclusion criteria. These solutions have that kind of baked into the cake. They typically have a little bit more sophistication around how they do the opportunity analysis and the analytics and metrics that they employ for that. They have pretty complete solutions around analysis and reporting for performance metrics, whether it's a commercial or a CMS bundled payment program. I guess where we see some variations here is that these vendors in general have had somewhat different focuses and different value props in terms of how they're able to market to providers. Some of them have limited service offerings, some of them have very full spectrum service offerings, including full source outsourcing, care management outsourcing to providers. And then just in terms of the functionality of the solutions themselves, there's some slight variations you see in terms of the extent to which these solutions offer functionality. But the vendors we've looked at, they typically have the most complete set of functionalities, in the marketplace. And with that, I would like to turn it over to Andy to give you just kind of a brief overview of Signature Medical's experience with BCPI implementation and the results to date that we'll be seeing head forward in the advanced BCPI program.
Excellent. Thanks very much, Matt. And thank you both to you and Hannah for having me on the webinar today. So a bit about Signature Care Management. Signature Care Management is a division of Signature Medical Group, a multi-specialty physician group that stretches across the state of Missouri. About 160 physicians in our practice, managing approximately 500,000 patient visits annually. We were awarded convener status in CMS's Bundled Payments for Care Improvement program, and then convener status again in the BPCI Advanced program. In the original program, we aligned with the biggest orthopedic groups in the country and built the largest independent orthopedic bundled payment program in the BPCI program. And our technology platform really kind of helped drive us and the clinicians in executing the program at a high level. We aligned with, again, like I said, those physicians across the country, managing over 150,000 episodes. And we're working in approximately 40 states at 413 hospitals in 84 cities nationally. What we've seen in executing the BPCI program from baseline to 2016 was a reduction in post-acute care cost of approximately 43%, while we saw a huge reduction in cost in the actual dollar amounts, almost $4,000 on average per episode. While at the same time, we saw huge reductions in adverse outcomes, P's during the index admission, surgical site infections, DVTs, UTIs, acute MIs within 7 days. Even the readmit rate reduced 24% relative to baseline. By analyzing the data, working closely with the data and the teams of physicians in the BPCI program, physicians were able to get a better understanding through patient-reported outcomes and what the clinicians were tracking, and then the actual claims data to get a better sense of if a patient was readmitted, where were they readmitted from, what were they readmitted for, where were they readmitted to, what was the cost associated with that readmit. It really made the physicians open their eyes and get an understanding of what actually happened for their patients to be able to adjust workflows in their process for their patients that they would see regularly. It really made physicians think outside the box in terms of patient care for what can be done effectively to treat patients on the front end to be able to reduce the adverse outcomes of patients on the back end. What we've seen with BPCI Advanced are a number of challenges in the most recent iteration of the program due to overlap with other models. The precedence rules within BPCI Advanced with physician group practices participating and acute care hospitals participating, clinical episode, hierarchy of the attending PGP taking precedence over the operating PGP and then the acute care hospital. And then obviously clinical episodes in BPCI Advanced, excluding beneficiaries that are aligned to the CJR program, the Comprehensive Care for Joint Replacement Program, ACOs, and other types of Medicare Shared Savings programs. There are complexities in case attribution in the BPCI Advanced program and from a number of different vantages. And we're working closely with CMS and along with a number of other parties and trying to get clarity into who actually controls these episodes. But really what we're seeing is that alignment across the care continuum for the patients, really with the data analytics to support efforts in care redesign, having that alignment, both with the acute care hospital, the physicians, the care navigators, and then the post-acute care providers, the inpatient rehab facilities, the skilled nursing facilities, home health agencies, all working collectively to better the patient experience and to help the patient through that episode of care is truly reducing cost, improving quality, and making these types of programs sustainable. HHS Secretary Azar recently suggested that mandatory models will be expanded upon. We've heard recently that CMS has been working on a number of different initiatives, mandatory initiatives and bundled payments, and we think CMS will continue to roll these out this year and into next year. We believe that this shift to mandatory is due to relatively small participation in terms of executing these types of value-based arrangements in CMS and CMMI programs. And the mandatory programs expansion really shows CMS's commitment to trying to push engagement to better control costs and improve quality.
Thanks, Andy. So just wanted to start the discussion now and take Q&A from the audience for the last 20 minutes or so of the webinar. And any questions we don't get to, we will follow up with after the webinar itself. So Hannah, did you want to start with the first question?
Thanks, Matt. Yes. Before we start our discussion questions, based on some questions we got, can you please clarify the differences between shared risk and gain, and how stakeholders decide to share both risk and gain? For example, is it a 50-50 split? What goes into that process?
I think it really depends on several different attributes in terms of what organization's looking to achieve with this. Is it something that they're looking to achieve a baseline reduction in the overall target price itself? Are they willing to engage in some type of negative downside payment for that physician, particular organization around this? Or is it something that the organization is looking to still provide some level of profit, but then looking to gain share on this? And then I think in terms of what we've seen, or the issues that we've seen, that it varies considerably. And I think it's very hard for me to say organization, even within procedure to procedure, where the opportunities may lie. So I think that there's so much variation that we have seen within organizations within a geographic area, and the opportunities that may lie there. Even within organizations themselves, we typically see a fair amount of price variation in procedure across different facilities within the organization, especially if it's across a wider geographic basis. It's really trying to right size it, right tune it for that particular marketplace. And it's really highly variable depending upon the organization itself, the volume we're looking at, as well as the number of procedures you're looking at doing this in the local characteristics of the marketplace. It's a long way of saying is that you see one organization, see one bundle, they're strong. And then you typically see a lot of characteristics of that organization. It's hard to make generalized classification or conclusions from that conversation.
Thank you. Moving into the discussion, to what extent do you see providers willing to engage in prospective bundles? And Andy, feel free to jump in. This might be your territory as well.
And you want to take that first, and then I'll finish with the comments I've had on some things we've seen with prospective bundles.
Yeah, I'd be happy to, Matt. I think what we've seen from providers in engaging prospective bundles is a willingness to explore the possibilities. Many of us know that these types of arrangements are mostly dependent on site of service to be able to actually win at these types of arrangements. But the sharing, dissemination, and analyzing of the data is of the most importance in these types of arrangements when payers are setting targets that providers then are going up against. To be able to get a true understanding of how those numbers are being calculated, inclusion and exclusion of certain procedures or excluding certain procedures from those targets to set up the arrangement is of the most importance. And I do think that providers are interested in these types of arrangements, but it does take a careful analysis of the actual proposal of the prospective bundle to determine if the opportunity is there as a win-win for both the payer and the provider, and most importantly for the patient. Matt, what do you think as far as providers' willingness to engage in prospective bundles?
I guess some anecdotal conversations that I've had in this area. Thanks, Andy, for that perspective. I've seen a couple of aggressive ambulatory surgical centers, either individual facility itself or maybe one that owns up to half a dozen ASCs in a particular geographic region, being a little bit more willingness to engage in prospective bundles and being aggressive in that, and basically looking to differentiate themselves in the marketplace. And not only looking within their marketplace, but potentially looking without their classic whole kind of service catchment area in terms of where they would typically do this, and looking to see additional opportunities, including the advertising devices. A couple of examples I've seen in the surgical centers. Advertising their prices directly on their website. I think that's still very much an outlier extreme, very much an outlier in this area. But from what I've seen, I guess IDNs have been very reluctant to engage in any type of prospective bundling, which makes sense because they have a lot of fixed costs and infrastructure that are associated with that. While they may have the ability and capability of staff or the number of personnel employed to address these solutions, there's just the lack of willingness to engage in downside risk in terms of prospective bundling, which you're seeing in general with value-based programs. Adoption value-based programs is somewhat tepid. I'd say prospective adoption of bundles that have been adopted from the marketplace and commercial providers, if I had to venture a guess, is 5 to 10% right now. It might even be lower than that in terms of doing this. And again, it's in areas where it's more of a strict procedure, partial hit, where you can get some economies of scale with that. Procedures fairly well known in terms of what the outcomes are and how you should proceed. And some providers are seeing this as an opportunity to differentiate themselves from the outpatient marketplace. But I think this is going to be some of us that will be some adoption, especially given how much risk the provider potentially bears in this if there's not some type of insurance agreement with the insurance corridor struck. And then really making using outside risk.
Okay. Are the costs, no. What is the role of post-acute networks in playing in bundles?
In terms of, I guess, what we've seen, I'll let Andy speak to this, given the macro perspective that Signature would have. Definitely starting to see a lot more formation of post-acute networks by larger IDNs in terms of actually starting to initiate and formalize an actual group or a number of post-acute providers, skilled nursing facilities, home health agencies in particular, where they actually do set up some type of contracting agreement in terms of sending their patients as preferred providers and getting some type of data collection from those organizations now it's publicly available to have a better understanding of how those organizations are performing. You're starting to see organizations in these spaces deploy maybe a senior vice president down to a director of post-acute, might be in the nursing capacity, it might be a separate standalone capacity. So I definitely think that organizations either have hired in this area, created new positions, and moved people over to this. You're definitely starting to see movement in the marketplace towards setting up preferred post-acute network formation among larger IDN provider facilities, even those organizations that own some level of post-acute facilities themselves. And I think it's going to be a trend that continues. The question is in terms of what IT and how the IT in those facilities can interact and help to enable bundled payments. I think it's still very much to be determined in terms of the lack of specifically IT infrastructure those facilities and organizations have, as well as the ability of those organizations to provide kind of biggest and greatest solutions for the facilities given their capital struggles and pricing reimbursement struggles.
Can you actually talk more about the implementation challenge of integrating clinical and administrative or claims data? Why is that so hard, and why is it so effective for or necessary for good bundled payment management? And Andy, I assume you also have lots of experience in this as well.
Absolutely. Being able to assess the claims data and implement a program successfully is absolutely essential in executing these types of initiatives. And to kind of continue on Matt's comments about the role of building post-acute care networks, it's that data that's really the driver for better patient care, especially with post-acute providers, to being able to show data that shows trends from the baseline and then current claims that are coming in and executing these programs. It's really helping the post-acute providers show that the care that they're delivering, the attention to detail, treating every patient as an individual, is getting the types of results that the physicians really want to see and the clinicians really want to see in executing these types of arrangements. Matt, any comment?
Yeah, sure. In terms of the challenges that we've seen here, just from again, this goes back to the analytics and kind of where healthcare has been in terms of historical payer claims analytics, of waiting for 30, 90 day, maybe more runout period. That's definitely helpful to help the organization understand where they're proceeding from this, but they really ideally need to have billing data to see how the organization is progressing or how the organization is doing instead of having to wait for longer durations of gaps in time, especially if you're not getting data on a monthly basis and you're just getting on a quarterly or longer timeline basis. So basically having some understanding of how the organization is doing advanced bundled payments programs that happen to wait 3 to 6 months in terms of lag runout. And then in terms of the clinical data there, outside the administrative billing data, is again, understand what's actually happening from a clinical perspective and having some insight into that as the patient's progressing through it, instead of getting a notification that they had, so a claim submission 3 days after the fact from the ER. So again, trying to just reconcile and get that access to that data in fashion from the clinical perspective to address clinical pathways and clinical pathway support as the patient's progressing through the bundle, and then the administrative billing data, just to understand basically how the organization is doing, and more timely fashion without having to go through a quarterly or potentially even biannual analysis.
Thanks. Can you talk more about cost savings drivers for outpatient procedures? You touched on inpatient drivers, but how do those differ for the adoption drivers for outpatient procedures specifically?
In terms of outpatient for orthopedics, I think that some of the difference obviously would be the main areas of difference would really be around this isn't necessarily a surprise given what Andy presented. So they've had data really on the post-acute side of things. So really focusing on the right service intensity of post-acute services, both from a site selection standpoint of view, in terms of being able to downshift patients to an appropriate care facility, but then also what service intensity of services do those patients need. So typically it means avoiding inpatient rehab facility and sending them to a skilled nursing facility. In a lot of cases, not even necessarily sending them to a skilled nursing facility, and sending them to or directly discharging them to their home, and then basically ensuring that they have the proper mix of home health, OT, PT, and other things necessary to that. I think that's where the biggest areas of savings have been. CMS results for PCP guidance and similar. And Andy, I'll let him give a little bit more explanation and feedback on that. That's really going to be on the post-acute intensity mix of services. That we're going to see that in the outpatient setting. Andy, do you have any thoughts on that?
Yes, Matt, I agree with you. Making sure that every patient is getting the appropriate level of care, the appropriate level of service at any given time of the episode is absolutely key. Managing the patient up front to be able to make sure that the clinicians are able to steer them and guide the patient appropriately for what the patient actually needs through the episode is key to this whole engagement.
Thank you. For our second to last question, Matt, can we go back to slide 11 with the market maturity by functionality chart? Yes. Okay. So for episode definition, what is the ideal episode definition you're looking for from vendors, and what are you seeing right now in the market?
I think there's two things. One, a number of vendors, especially in the commercial space, are using the Prometheus grouper, which is available. We've had varying conversations about how successful that vendor, that grouper is, in terms of meeting the needs for commercial payment programs and actually implementing that grouper successfully. So again, successfully maybe more of the lack of solution in the marketplace. In terms of the ability of these solutions to define carve-outs and where we address that from a contract management standpoint view, there's varying degrees of sophistication from what we've seen in the marketplace. And then I guess lastly, in terms of the episode definition itself, is to how quickly and how long is this taking the solution. So some of the solutions, it's pretty intuitive. You can go right in the solution and also business rules. Some of them is a little bit more complex in terms of the coding that's needed to accomplish that from a IT perspective. You need more of a business to accomplish that, to be able to meet that goal. And I guess lastly then too is this area of kind of risk management or risk attribution in terms of the actual episodes themselves and how that is being incorporated into the actual episode definitions. There's certainly the inclusion and exclusion criteria, which are a little bit more straightforward, usually depending on procedures that are done to that patient in the episode, which is following further participation. But the idea of handling the risk up front and then being able to address that with the actual episode definition itself is something that we're seeing, I'd say, very increased frustration on. And then that potentially results in other problematic issues with this, including cherry picking of patients for which elective procedures may be performed and other types of unintended consequences that we're seeing in the marketplace. But again, it's really not necessarily a problem with vendors per se. It's necessarily can the vendor actually do that within their solution place, and that's some of the solutions that are available in the marketplace, especially for commercial programs and probably that. So I still think that it's all working judgment in terms of what's currently available and incorporate some of the challenges in commercial programs.
All right. Well, for our last question, really the one we're all wondering, Matt, Andy, are bundled payments really going to save money?
Andy, do you want to take that one first? Sure,
I can take a stab at this, Matt. So what we've seen in the BPCI program has been a successful program. We have seen the saving of money to CMS, and more importantly, we've seen that reduction in those adverse outcomes. It really takes a concert of individuals, though, across the care continuum to be able to save the money. Being able to align the hospital again, the physicians, the care navigators, and then all the post-acute facilities together to actively manage the patient through the episode. It can save money relative to the targets that CMS sets in these types of arrangements. Any comments, Matt?
Yeah, I guess I had to make a comment. I think it varies greatly depending upon the organization, the starting target price that they're in, and the characteristics of the market. What is the actual reference price for the actual bundle that's being set in terms of doing this? If I had to ballpark guess this and the results that I've seen out from the BCPI program, other anecdotal conversations I've had, I'd say on the high end, 8 to 10% maybe for a procedure in terms of the actual cost savings that are readily achievable. On the lower end, 1 to 3%. I think a lot of this is really, again, just kind of a downshifting or downscaling in the post-acute environment in terms of the appropriate environment, just simply avoiding inpatient rehab facilities in general, or limiting SNF stage or avoiding SNF stage. There's always some issues and complexities about maybe that results in more adverse outcomes. The evidence is a little more cloudy mixed on that. But I do think that they can save money. I do think that you will see them being scaled a little bit more in some of the critical service line areas, orthopedics, cardiology, oncology, moving forward, a couple of other service lines. So I think that they're here to stay. I think that they can save 5 to 10%, or take a little bit, depending upon several different factors for a bundle against the reference price. I guess the question is the organization be able to make the investments it needs and be able to actually recoup those savings given the number of IT investments that they have to make, modifications, and generally additional modifications and hiring additional personnel to accomplish these solutions. That's the biggest organizational challenge that we've seen, that making those initial investments and then being able to scale these programs appropriately is a real challenge. Not the bundled payments programs, but I think in general, provider led to for these payments. I think that they can work. I think it's just we're talking about right now to be able to scale them and scale them efficiently for provider organizations. And we may need to monetize that savings in a more readily available fashion.
All right. Well, with that, we have reached the top of the hour. Thank you, everyone, for your questions, and I'm so sorry we couldn't get to all of them. If you'd like to follow up with our presenters, please leave a comment in the follow-up survey right after we end, or email Matt directly. And thank you, Andy, for sharing your experiences with administering bundled payment programs. For more information on bundled payment programs and a deeper analysis of the IT tools available, I encourage you to check out our new report. I'll include the link along with the slide deck and recording of this webinar in my follow-up email in a few days. Thank you for joining.